My name is Mary Gracie White. I am the Clinical and Regulatory Compliance Director for Greater New York Healthcare Facilities Association. Thank you and welcome to today's presentation on advances in wound care. We are pleased to collaborate with the Castleton Group, represented by Lowell Feldman, Casina Care, represented by the Vice President of Clinical Services, Lisa Garay, and Tony Pinto. Today's program will provide you with insight into evidence-based wound care, as well as the use of innovative technology to prevent and treat pressure ulcers. My experience as a wound care nurse and as a clinical advisory and coach for the New York State Gold Stamp program has strengthened my commitment to reducing and preventing pressure ulcers. We are very happy to bring this program to you today. Our current rate of pressure ulcers in New York, according to the National Nursing Home Alliance, formerly known as Advancing Excellence, is about 6.5%. Nationally, the rate for long-term care residents is 5%. So we have done great improvements in New York State, but we still have a long way to go for our residents and to promote quality and efficient care. So it's my pleasure to introduce to you Lowell Feldman.
Thank you, Mary Grace. Good afternoon to everybody. For those of you who may not know me, I was a nursing home operator for close to 40 years and still maintaining my administrator's license, but out of the day-to-day operations and more into the world of technology. I'd like to initially thank everybody here for allowing Castleton Group to launch this first live session presentation to the industry, and of course Lisa and the Upper East Side and Casina for participating and moving forward in the world of technology to improve healthcare and long-term care. So with no further ado, I'd like to introduce Lisa Garay, who's been spearheading the introduction of technology in the Casina facilities, especially at the Upper East Side, where we've launched some interesting and very, very exciting approaches to providing quality care and easy access to professionals. So Lisa, it's all yours.
Thank you. Thank you, Lowell and Mary Grace, for inviting Upper East Side Rehabilitation and Nursing Center to be a part of today's seminar. Upper East Side is a 499-bed facility located in Manhattan, and we are very excited to share some of our experiences with how technology has supplemented our wound care program at UES. So today we're going to cover how technology supports the wound care program and how it can be a part of our everyday workflows. So the landscape, certainly in long-term care, is rapidly changing, and many of the skilled facilities are facing increasing pressure to improve clinical and financial performance, despite the many lack of resources and greater expectations inherent in many of the healthcare reforms that we have been experiencing in New York State. And certainly what we're seeing now is a shift from volume-based care to value-based care. So we're looking towards more, how do we make care more cost-effective? What is the quality outcomes that we're looking at? And how do we deliver the care in a more efficient way? And much of this is being tied into the patient experience of care as well. So much of what we do around our patient care is we're trying to ensure that our outcomes are appropriate and that they're part of the care. And much of what we're going to talk about today around telemedicine is that they are becoming much more educated about care and are looking towards us to be more innovative in the way that we're delivering care. We're also seeing a change around improving the health of the population. And so many of us are looking at specialty programs and our clinical capabilities around those specialty programs. And so looking at outcomes around congestive heart failure, COPD, and pressure ulcers are all important parts of our service delivery, which then ties into how our data and our outcomes are showing those improvements. And so much of our decision-making in long-term care and how we are rated is based on our data and some of our outcomes. And I don't have to tell anybody in long-term care around the pressure of maintaining the 5-star ratings and how that the implications of those rating systems are impacting our ability to get managed care contracts, to keep our health partners in the community. And it all ties into the advanced technology. I mean, every skilled facility wants to be on the advances of technology. And how do we take technology to make our business more efficient and optimize those outcomes? So when you look at all these 5 components, this is really where post-acute care is being driven. So at Upper East Side, the telehealth strategy, when we sat down to do our strategic planning for the year, we began to look at those 3 concepts of cost reduction, of outcomes, and patient experience. And we felt that telehealth really supported those 3 main areas. And when you begin to integrate telehealth into your daily workflows, you're able to, you come to the realization that it does help us to increase access to care and collaboration. And so the more that we, with the telehealth, you're able to access a physician 24 hours a day from whatever location, and certainly the medical services are key to the outcomes. And so through telemedicine, we've been able to do that, an increase in collaboration of care. So many of our patients are not only being covered by a primary care physician, but they're also covered by many specialists in the community. So the telehealth is able to bring all of those professionals together and look at the treatment plan for the patient. It also helps to improve coordination of care at various touch points. I mean, many of us are involved in warm handoff programs between hospitals and the skilled nursing facility. And so the telehealth is able to pull all those people together, whether it's from the hospital side, patient side, the physician, home care, and sit down and have a discussion about the coordination of care in order for the patient to move back to the community. The third component is really around efficient and effective care to reduce readmissions. So in New York State, many of the facilities are still anywhere between 18 and 20% for readmissions. And so the telehealth allows us to use it for after-hours coverage, and so that the physician is doing a much more thorough evaluation of the patient. It's not just the nurse making a phone call to the doctor and providing them with some data. During the telehealth visit, the physician is actually doing a video conference and using some of the ancillaries to do a complete evaluation of the patient, listening to breath sounds, listening to abdominal sounds, being able to ask the patient questions so that diagnosis and treatment are much more accurate. And our goal at UES is to begin to use the telemedicine for these after-hours calls. And it's not to take the place of the face-to-face with the physician. That still is essential, but it certainly does supplement the care that you provide in the facility. And lastly, the telehealth helps with the patient and family engagement. And as I said, it's important that the patient is educated about their condition, that they're able to go back to the community and be able to self-manage it. And this system allows us to bring the family and the patient together, and so that they're more engaged in the care, they're participating in care decisions, and moves them to a better position so that they stay in the community and are not rehospitalized. And I think over the next couple of years, you're going to see that the telehealth market is really growing, and they're predicting almost a 60% growth in the market over the next couple of years. I think state by state, there's different regulations. New York State, the regulations are still in draft, so there really isn't reimbursement opportunities around the telemedicine. I think that will start to move as we're starting to see this really take off. And telehealth has been used for many, many years in the hospital setting, in ICUs, and we're starting to see more of it move into other niches in the market. So what is telemedicine? Telemedicine is really a convergence of the computer and telecommunications technology used in providing care. So this is a picture of what a mobile cart looks like, and you can see there's the doctor video conference is in, while the nurse and the patient are in either in a private room or within the residence room, and a complete visit is conducted. And there's various ancillaries off of that mobile cart. So you can do, it's real-time video conferencing. You can store and forward information. So, and we'll demonstrate in the video that we're going to show shortly of how an actual telemedicine visit takes place and how the store and forward functionality of the system works. And you can store and forward wound care information, a suture line, and we're beginning to use this system much more with the specialists in the community. So when you look at your patients with a joint replacement, where you have to set up a visit to go see the orthopedic doctor to determine whether it's time to take out the staples, you can actually do a telemedicine visit with that specialist and not have to set up transportation and take the patient over to the doctor's office. So there's a lot of applicability to the system in the day-to-day workflows within the facility. So how does it work? The nurse sets up the visit with the physician. She sets up the video conferencing over the internet. As I said, there are ancillary devices off of the system where the doctor drives the visit. So the doctor will instruct the nurse to listen to breath sounds, listen to abdominal sounds. We can do a full set of vital signs, pulse oximetry, EKG readings. There is a full camera so that any close-ups of suture lines or bruises or wounds can be done. There's also an otoscope that can be used. The doctor does the visit just as he would conduct the visit as in a face-to-face format, and then documents the treatment plan in the electronic medical record. So at UES, we've used the telemedicine in really two fashions. One is for after-hours care, and the other is for our wound care program. And as I said, the telemedicine is really a supplement to that program. And it allows us to treat patients at any time, anywhere. It allows us for timely follow-up of those of post-surgical wounds or chronic wounds. But more importantly, if a wound changes in its appearance and the physician is not on site or the wound care specialist is not on site, we're able to dial in the physician and take a look at it. So when you talk about timely care, you know, this is an opportunity to catch wounds early on if they're changing in some fashion, change the treatment plan, change the care plan, and address the needs of the patient much quicker. It also enhances communication with the wound care specialist. As I said, it's not just that once a week when the wound care specialist may be on site to do rounds. This allows us to communicate with them regularly. And if we have to call in any specialist, a vascular surgeon, we can dial them in. And again, it reduces the need to travel. I'll give you an example of other ways that we're using it outside of wound care. We work with a hospital around their COPD program. And so we're able to get the pulmonologist to video conference in to see the patients and talk to their patients that they're going to follow out in the community. So it really is a technology that has changed the face of medical care and has made us much more efficient as a skilled facility. And we really are able to address changes in condition more timely. And I think it really has added a tremendous amount to the facility. And the patients have to say they've been very open to it. Families have been very open to it. And when you look at, our life today, everybody's on the phone, everybody's using their computer. It is a very digital society now. And, we're very pleased to be a part of that change. So the wound care program at UES, the way we have organized it, which is probably very common to many of your programs, is that it is an interdisciplinary team approach. It's physician-driven with a wound care specialist and a wound care nurse. We do use best practices and the technology that we talked about. And it's really about two key components, right? It's about a prevention component. So when you look at your CMS regulations and the practice framework that we utilize, we're always functioning in a preventative state. So how do we prevent people from getting pressure ulcers? And then there's the treatment component. And the treatment is, you want to make sure that you're using best practices, evidence-based protocols. Mary Grace talked about the Gold Stamp program and having pressure ulcer protocols that are consistent. And so that's really makes up our wound care program. And then we put the overlay of the telemedicine program on that. So some of the challenges that we see in around assessments and wound care, you know, it's certainly all around building the competency of your staff and that your staff are able to recognize common types of wounds in order to identify the right treatments. And telemedicine is also a way, if you have a nurse that's unsure of the type of wound or the treatment modality, this is also a way for her to, or him, to dial in the physician and have somebody in a collaborative fashion say, I think it's this kind of a wound. And so again, treatment becomes much more accurate. So when you look at some of those challenges that we all face about accurate and timely assessments with new admissions, implementation of care and treatment, and how we document that care and the care planning. You know, you certainly want to make sure that you're documenting correctly or making that assessment correctly from the point of onset so that you are starting down the right path with the appropriate treatment. And again, this is a way of helping that nurse to feel that she has the support of making the right assessment, that she's not there by herself making the assessment if they're not clear on the type of wound. So key components of the wound assessment, you know, for those of you that have been in long-term care for a long time, this is not new for you. And you know, it certainly, as I said, is not, assessment of a wound is not an exact science, but does require skills and assessment of a trained practitioner. But it's important to really determine etiology, being able to look at the description, the surrounding tissue, the location, size, and depth, staging, and so forth. And the other component of today's presentation is looking at how eCare, which is another wound care solution. You'll see when Tony talks about the device, how that device is going to really help capture this key information, be able to track the information and trend information. And so it's very exciting to pull together the eCare with the telemedicine. So eCare, just a little bit of an introduction to it. It is a wound imaging solution, and as I said, Tony is going to do a whole segment on the eCare and explain it. But it does it's a 3D functionality that is able to look at the wound borders. It helps us to document assessments and treatment protocol, and then the dashboard. And I have to say, out of all of the functionality of the system, the piece that I'm excited about is the dashboard, because you can look at over time whether your wounds are healing or they're deteriorating in real time, and you can make those changes very quickly. So it has a lot of great applicability for the skilled care area. Okay, so now we're going to move on to the video, which is a fictitious presentation. The actors in here were all volunteers. They're not real people. They're not real patients. And they're going to demonstrate how a telemedicine visit takes place, and so that you can get the feel of the system and some of the technology that we're talking about.
Good morning, Fiona. Welcome to our telemedicine room. We are with Dr. Powers right now. Good morning, doctor.
Hi, good morning. How are you?
Hey, doctor. Nice to meeting you.
Okay, I understand you're having a little bit of pain this morning.
Yes, I have a pain all the time.
Okay, they sent me your vital signs. I can see in your vital signs you have a temperature of 100.8. And I understand that the pain is right around where the pressure ulcer is. Has that been all night? You've been feeling the pain?
Yes.
Okay.
I can sleep, I can eat, I can, breathe.
Okay. All right, we're going to look at your pain medication, but what I'd like the nurse to do is to order an x-ray to rule out osteomyelitis. And also, if you could put in for a CBC lab, and also change to for an antibiotic Keflex 500 milligrams PO every 6 hours, and also change the dressing to a hydrogel with dry protective dressing to be increased twice a day, just so we can monitor it. If you could also send me a picture of the current wound so I can take a look at it and we can see if there's been any deterioration with the wound.
Okay, we'll do, doctor. We'll take a picture of it and do the current assessment and we'll send it to you.
Okay, I appreciate that.
I will be turning you, as Dr. Powers has said, you need to do an assessment. I will be taking pictures. I will just want to let you know that. I will be taking pictures and I will send it to Dr. Powers. So, Dr. Powers, you've already received the picture of the assessment of the wound?
Yes, I did. I received it.
Okay, doctor. So basically, with all our assessments, our wound edge is now epithelialized. Periwound skin is filled with redness. With pain during our assessment, Ms. Yelena rated it as 8 on movement. The drainage, we have moderate sanguinous. With others, we still have the others, other coming from the wound. With pressure staging, we are stage 3 before, and now we are staging it into stage 4. So do you have any orders, doctor?
Let's continue with the hydrogel twice a day, Keflex, and we have to monitor as far as the odor or the drainage if that increases at all. Let's continue with the same pain management. Monitor if the pain doesn't increase. Make sure that we treat before the pain management before treatment, and we'll just see how the pressure also goes. Let's monitor it on a daily basis.
So Yelena, we did the assessment already with the doctor. Dr. Powers, thank you so much.
Do you have any other questions for me, Elena?
No, doctor. I hope it's gonna work. And that will feel better. Thank you very much.
I'll monitor it on a daily basis, and I'll follow up with you tomorrow.
We'll do that, doctor, and we'll update you.
Thank you.
Well, while Lisa's getting her screen back up, I would just like to add that Dr. Powers is an impersonator, and he's really Keith Powers, an administrator who did a wonderful job in this simulation. It's all yours, Lisa.
Yes, I also want to thank Jennifer Jaspy, who is the ADNS at UES, who has really been a phenomenal leader in taking full responsibility for getting the telehealth off the ground and does some of our other specialty programs and is really just a wonderful, wonderful caring nurse and so good at what she does. And Keith Powers is one of our administrators from another facility who's always game to play along with anything we ask him, and Yelena, who's one of our activities. So they did a great job with the video. So I'm going to turn the presentation over to Tony Pinto, who is the Vice President of Business Development at eCare, and is going to go through the device that you saw Jennifer use in the handheld laptop there that she's going to go through. He'll go through and what she was, the data that she was capturing and show you some of the screenshots in eCare. So Tony?
Excellent. Thank you, Lisa. So as you saw from the video, eCare system is a cloud-based mobile device. It allows for a quick and easy and accurate measurement from a 3D perspective using infrared light at a short distance to take a photo of a wound. When you navigate to the patient list and find the patient that you're providing wound care for, this is essentially the first screen that provides you access to the entire system. Very simplified, just a few screens. The wound summary screen, which we call the dashboard at eCare, provides clinicians the ability to add new wounds, to track multiple wounds for a patient, and as the data from each measurement is added to the system, the trending around the depth and the area and the tissue classification for that wound is calculated and viewable both from the iPad mobile device as well as the web portal. The gallery of photos, current and previous, easily accessible here by clicking into the wound photo and then paging back and seeing the data associated with each of the wounds. First order of business really is to take a measurement quickly and easily. Hitting measure allows the clinician to take the device and quickly, within seconds, 7 to 10 seconds, capture the image, store it in the cloud, accessible on the iPad, as well as the portal. And as you see here, due to the 3D technology, the area, the depth, the length, and the width, the tissue classification for that wound is captured, again, within seconds. Clinicians are also prompted, based on how well they took the photo, whether there's a quality indicator, whether maybe the shot should be taken again, adjusted for angulation, maybe the lighting, things like that. But the system, the iPad itself, helps guide the clinician for the distance, the right distance to be away from the wound. You'll also see here the ability to edit any of the data added to the system following the measurement of the wound is also easily accessible to the clinician. In addition to capturing the photo and the measurements and having that within seconds, the second tab is the assessment area that allows the clinician to really very quickly get in and assess and capture the wound edge, the peri-wound, the pain, the drainage, the important items that Lisa mentioned before, as well as tunneling, undermining. You can stage a pressure ulcer wound here in the assessment. And the push scale will be automatically created once the photo and the assessment is completed. Braden scale can also be completed here in the assessment area of eCare. Each assessment that's carried on will bring the data forward, allowing clinicians to easily update as they go forward. In addition to that, the third screen allows the clinician to add the treatment documentation. Wound care protocols can be customized per facility here very easily from an administrative standpoint, adjusting for the formula that you may have in your facility, as well as the frequencies that might be specific to your facility and your organization. So it's essentially three very quick and easy screens to document during your wound care rounds or after the wound care session. That data can easily be taken and shared into your EHR or shared with clinicians outside of the eCare system via a PDF, which is easily created and can be shared securely with a physician or anyone else with a DOH. In addition to the PDF, as Lisa mentioned, the value around the analytics piece, well, I'll show you in the dashboard in the next screen, the data that's provided both at a facility and at a corporate level, allowing you to track and trend the wounds and to see the activity that's happening in your facility, providing tremendous value, especially at the leadership level. And this is a screenshot of that dashboard, providing folks the ability to look at the wounds, the most prevalent wounds, the locations of those wounds on the patient bodies, as well as some percentages around those types of wounds. In addition, some activity levels around how many patients have been seen, the measurements, as well as the trending and the healing process for those wounds, as you can see down at the bottom. Provides tremendous value to be able to take that data and share that externally. This data can all be shared via CSV or Excel file right from the eCare system and saved and shared and analyzed for your organization.
So when you, just to talk a little bit more about eCare, so some of the efficiencies that we've gotten from the system is one that it's able to track and trend the roster of wounds that need to be cared for in the facility. The protocols have been all standardized in the system, so you can build into the system your pressure ulcer protocols so that you're standardizing care across the board. And at the end, the information, whether it's the treatment, the measurement, all comes out into a PDF and then is placed into the medical record. We are working at UES, we do use point-click care. And so there is an interface so that all of the admission of once patient is admitted into the facility, it automatically goes into the system. We are working with Point Click Care to get the eCare system interface with the documentation within Point Click Care as well, which will add an additional efficiency. But when you look at how the nurse has to document, she does the rounds, she has to go back to the medical record and document it. This system really incorporates everything at one point of care. So, and as I said, we're really able to look at it across the board, every wound in the building, and whether we can determine the percentage of healing as well as the percentage that are not healing. So that's, I think, the beauty in the analytics. So some of the challenges and next steps, as I said, the technology, the telehealth is going to move into much of the healthcare space. It's happening all over the world. When we had our system, when we had AMD come in and set up our system, the gentleman was telling us about how he was in the Tibetan mountains setting up telemedicine throughout the mountains that all were connected to one main clinic in Tibet. And when you look at how this technology can really change care and how it can reach so many people that are in rural areas, it's phenomenal. And as I said, we're very excited to be able to have it in the skilled nursing facility, because I think it's just going to add a much higher dimension of care and looking at how we utilize resources better, and most importantly, our outcomes. I think some of the lessons that we have learned with the telehealth is really around the learning curve and helping staff to incorporate the technology into their care and change, right? Many of the physicians that we've dealt with were somewhat reluctant at first. They're like, I don't know, I really like the telephone better. Why do I have to do this? But once you get them around the curve and they're able to see, the interaction with the patient and how much more accurate the diagnosis and treatment is, they really embrace it. But I think if I look back in lessons learned, I think I would have done a lot more work with the physicians in getting them to embrace it and understand the reach that it has and the impact that it does have. The patients, as I said, were a much easier sell than some of the physicians. They were because they are accustomed to using the technology. So that really concludes our presentation today. Again, I'd like to thank you for your attention, and if you have any questions, we're happy to answer them.
Yes, thank you, Lisa. Appreciate it. I think that was a great presentation, and I know everyone knows the value of wound care and patient outcomes, as Lisa mentioned, and as far as quality measures, survey results, patient satisfaction, family satisfaction, utilizing this technology or investigating it, and we'll have the opportunity to provide you with additional information. And with that, I'd like to turn it over to Lowell, the moderators, to see if we have any questions.
Okay, thank you very much, and wonderful presentation. Personally, I must say, I go back a couple of eras on training the workforce. When I was the chair of education for the state association back in the 80s, we launched the first nurse aid training film, 18 modules. It was called First Step, that the health department ever approved and actually won awards for it. So this now, 4 decades later, bringing this topic training to you with the new technology to the industry is heartfelt, and I really do appreciate Greater New York and Casena for providing us, the Castleton Group, this opportunity. For years also I worked with NDIC on behalf of Greater New York with the labor coalitions and other associations to increase education and training to the industry, from violence in the workplace to emergency preparedness. And this is a whole new era and capabilities for us to share information on this platform with the industry and with those in the industry who are using the technology. The technology, as Lisa indicated, it's amazing. It is worldwide. Castleton Group has clients worldwide. We do what we feel provides solutions. Every facility is different. You could be 500 beds like Upper East Side or 40 beds. Everybody has different needs and different focus. The focus here began with after hours and wounds, and it's going to grow. Other facilities have just dealing with behavioral health, just bringing the psychologists, psychiatrists unavailable and to come in all the time, to be there for episodic events, and also for screening. Let's not forget your MDS is changing. The rapidness of how fast you have to assess the patients, especially after hours admissions from all disciplines, can be done like this. Lisa also, she's a little shy today, has embarked on another technology. It's called the NICAS device, NICAS. It's a hemodynamic monitor. It's been replacing the necessity for patients to go out for Swan-Ganz catheterizations, and maybe on the next episode we'll deal with cardiac and pulmonary care. But I was with Lisa the other day, and the results that they're getting from that technology, which was Israeli-developed technology, FDA approved and billable for as a test, is really keeping patients in place. Example, it was tested in the Kindred system, 72% reduction in readmissions from the nursing home back to the hospital. So the world of technology in healthcare is unlimited. It's growing. I will have to clarify one statement. The reimbursement is there in New York. Depending on physical location of where the patient is, in rural areas, CMS, Medicare pays equal to a full visit Medicare rates. In non-rural areas, Medicaid, since 2016 passage of the parity law in New York State, Medicaid can be billed, and many of the managed care and private insurance providers are paying equal rates now for telehealth, knowing that it's preventing rehospitalizations, it's keeping patients in place, it's giving the family ability to participate and collaborate in the medical examination and care planning, regardless of where they're located. And the outcome from the residents has been very, very successful and accepting. So with that, I'd like to see if anybody would like to ask questions at this point. On the bottom of your screen, you'll see a QA, you press that button and you can click on and ask a question, and we'll be responding. So hopefully there are some questions out there. I'll give it a few minutes. The first brave person.
Well, there is one question. I can repeat it if you like.
Sure, go ahead, Howard. This is Howard Reese, a partner of the Castleton Group, one of the founding partners.
First, a comment, then I'll repeat the question. But emphasizing what Lowell said, while telemedicine is becoming more accepted, one of the things we've certainly learned, there's no off-the-shelf solution or one-size-fits-all. It really depends on the individual needs of the individual facilities, and to be able to come and do an assessment, figure out what problem is trying to be solved through telemedicine, to set up a program so that outcomes can be measured. So we're at the infancy of this. We are convinced that it's going to become widespread, but it really does require a certain degree of hand-holding, and that's really what we're doing at the Castleton Group. Well, I'll just read the question that came from Peggy McGee, and we'll turn it back to our panel, but it said, based on your studies, what is the accuracy of the measurement, et cetera, by a wound care nurse versus this technology?
Yeah, and I can provide just some background. The eCare device has been through numerous research trials. You can go on our website and see the white papers and the levels of accuracy captured at 95% or greater in terms of accuracy on the measurement that's obtained. So.
Great question also. Are there any other questions in the queue?
I'd like to add something else. In addition to this, for many facilities, they don't have the luxury of having their own certified wound care nurses available at all times. There are companies forming now, and we interact with some of those as well, who have certified wound care nurses who specialize in wound care assessment via telehealth. Some using eCare, some other devices, and these are now available. So for your after-hours admissions, when you have to do that skin assessment, make sure there's no reddened area that you didn't see 2 days later, Monday morning, when mission came in on Friday, to have certified wound care nurses and have the ability to assess complete skin needs, whether there's wounds or not, on admission, and then monitor. It's another avenue of being able to access the professionals you need at lower cost. They don't have to be full-time, and provide the services in a timely manner. I know MDS changes. Again, I'm not an operator anymore, but maintaining my license. And I know there's changes coming to the MDS that are going to be focusing on wounds and on COPD. And in order to meet those needs, you're going to have to, just like we could transition most of us to electronic medical records, start using the technology to meet the timeliness of the care that we have to provide now, and the more post-acute and chronically ill patients to get the specialists to the patients and not have to transport them out. So if there are some more questions, let's hear them. I see something there.
Well, there is another question from Faith Waller, and her question was, is this in the VA hospital yet?
I can answer that. The VA hospital, in different areas, not all of them, but many VA hospitals have been very proficient in the world of telehealth. In fact, the Castleton Group, as of this week, recently is going to be working with one out in another state out in the West with the hemodynamic monitor program and telemedicine. But yes, VA hospitals have been using telehealth, and hopefully if the VA medical bills pass and allow veterans to go anywhere for their service, if they're not close to somewhere, it'll actually be enhanced when those bills pass.
Well, just to emphasize that the specific area where the VA has taken a leadership role has been in providing telehealth to veterans in a home setting.
Yes. And you know, I'd like to mention something with that, Howard, because when we set up the systems at the Upper East Side, Lisa mentioned AMD, which is a telehealth communications company that's been around for 25, 30 years with a lot of institutional quality grade equipment, and they're worldwide. We also brought in another software platform and integrated it with AMD, which is going to allow the Upper East Side to, upon discharge of their residents, monitor their patient's condition by simple use of simple technology, smartphones, Androids, Apples, laptops, and some peripheral devices that are Bluetooth connected, such as pulse ox and weight scales and BP. My BP goes Bluetooth every day, and my glucose goes Bluetooth every day to my computers. And this will give the facilities the ability to monitor patients post-discharge by their own guidelines and marks, and be able to see if the patient's out of range in their follow-up, again, to prevent rehospitalizations and keep those 5 stars in quality ratings. So it's not only in the facility, it can be pre-admission and post-discharge to continue caring for the residents and keeping their families informed.
Thank you, Lowell. Thank you. We appreciate it. And again, if there are...
We have one more question that came in.
Oh, great.
From anonymous viewer, but the question is approximately how much would a facility have to invest in the telehealth technology? And I'd like to answer that. It really depends on the specific needs and the use case. One can start very simply and inexpensively. We like to tell folks, you know, at the very easiest, this could be equivalent to what you're paying on a monthly basis for your cable TV bill. Certainly, as it becomes a little more involved and more sophisticated and using more peripheral equipment and devices, you know, the price can go up. So it really depends on an assessment, what you're looking for. But in terms of just the basic video technology, it's actually surprising to folks how affordable it is in terms of getting started.
I would agree with that, with what Howard is saying. The price points are vary from very inexpensive to, depending upon the type of peripherals you purchase for the cart. But it is very reasonable, and I think the prices, just like with anything around technology, once it gets out in the market, the prices become a little bit more acceptable to providers.
And there's another question that came through the chat room from a Teresa Barnes, wanting to know if the Castleton Group assists in this. And the answer is yes. Again, we don't manufacture anything ourselves. We're solutions. We are integrated and collaborate with numerous companies, again, such as AMD, such as CareSpan, such hopefully very soon, Tony, with eCare. We've been talking since we're doing this together, and numerous other activities. I mentioned some of the professional services that integrate telehealth services that use our platforms that we suggest. And again, as Howard mentioned, it's based on facilities' needs. Some facilities just say, hey, I really need a psychiatrist in behavioral health. Well, you don't need much for that. What you're looking on now, your laptop can be good, or a large screen that we recommend in a quiet area. That we did that back in the 80s in Wellsville, New York, before Wi-Fi with telephone lines. Now it's advanced, and that's a very big area, intervention in behavioral health. So the answer is yes. We come just like you have to be required now to assess your facility and what type of care you're going to be providing and how you're approaching us. We help you with the assessment to determine what type of needs you need and implement, and assist in the training as well. You just can't give you something and work it. The training to the personnel, again, go back to the training when the eHealth record, SigmaCare, was launched in New York State. There was training modules, and I think this is a wonderful platform for training and interpersonnel, just like the simulation, which, by the way, was wonderful, and thanks for the staff at Upper East Side for putting up with us in our direction on site and from Arizona. But the integration and through NDIC and the association, so many of the education programs now are based on simulations and tabletop exercises and working with personnel. And you can, on this platform that we're using, Zoom, which is the foundation for many of the telehealth programs we do, these can be recorded, these sessions, used for training and shared, and also for facilities that have large numbers in multiple facilities, used for interfacility training, just as we're doing it right now. So when you're making the investment in telemedicine, there's peripheral advantages that go along with it as well. And as Howard mentioned, the expense is certainly worth the investment.
Hey, Lowell, we've got another question that came in through the chat room. It says, for behavioral, I was informed it will take some time to figure out how to bill for it. Is there a targeted group we may target to assist or advise?
Well, let me answer that a few ways. Again, the reimbursement on behavioral in the telehealth guidelines in New York State, it indicates levels of practitioners who can use it, and certainly psychiatry and social workers and psychiatrists are in there. And again, the billing is based on the location of the patient. So if the patient is in a metropolitan area, that it could be Medicaid, it's Medicaid only. In rural areas, Medicare by zip code, Medicare will pay. And there are a number of organizations, and we do interact with some with behavioral health specialists that will offer their services. It's not common or past practice in the industry, but the doctor will be available on a per patient visit to the facility. And sometimes you have to weigh the cost of that versus transporting the patient out to ER and having them sent back again for an episodic event that historically, especially in the New York City area, is just like a revolving door of behaviors going in and out to ERs. And some facilities have taken that and made that investment in working out relationships with provider groups, if necessary, cash. But and what I didn't mention, a few weeks ago we met up in the commissioner's office with the Department of Health, and when Lisa mentioned drafting regulations, the health department had 25 drafted revisions of the regulations on telehealth, which recently they just set aside, and the regulations are not going to affect. They're just going to, as Mark Kissinger mentioned, mirror the legislation on telehealth, which opens up a much more wider capabilities. and and we did mention reimbursement as one of the obstacles. And from the viewpoint of the health department, they want to minimize the obstacles to the spread of telehealth in New York State. The hospitals are using it, ICU to ICU. School systems, we work with upstate New York and Rochester that have done over 15,000 visits in school systems. And we met specifically talking about long-term care and home care and reducing the barriers. So there is reimbursement, and certainly depending where you are in your facility type and what you're looking for, we can go through it. And we do actually have practitioners who are providing behavioral health services in facilities. I hope that answers the question.
Well, one more quick point from this side. The Castleton Group, we've got many years of experience in telehealth. I think you can tell by Lowell's passion. We love talking about it. So please, the website is thecastletongroup.com. Contact us, ask any questions you have. Happy to engage in a conversation, tell you what works. Also, through some of our experience, what in some cases hasn't worked, and happy to share with you a little bit of our vision of where we're going from here.
Okay, Mary, and we're at the 7-minute part. And by the way, again, none of us are rehearsed professionals. So for you in the audience, thank you for tolerating us. But we're looking forward to see how this is received. I know there will be a evaluation sent out to everybody who's attended, as required by the Board of Examiners. Thank goodness Mary Grace and the association got an hour's credit for this presentation for administrators. And we'd like to see how this platform, the presentation, was accepted versus some of the webinars where you're just looking at whiteboards in one way and no real interaction. Actually, the interaction on this platform we can enhance, and you viewers, if wanted to, could actually show up on screen as well in the future. But this was our first go-round with Greater New York on this approach to providing education. And hopefully, if you accept it, we'll be able to continue and do more on subject matters with telehealth or any other presentation, seminar topic we need. And certainly, it is growing, the telehealth industry worldwide. We're currently working with Latin America with a physician group that represents 4 major hospitals in Mexico who've come to us to provide second opinions for patients in Mexico who want second opinions in specific specialty categories. And so it's not anything that's going away. If anything, telehealth is the future of population health care in America and worldwide.
Okay, great.
Thanks, Lowell.
Okay.
And thank you to Casino Care, and thank you to the Castleton Group, and of course to Steve, and hopefully we'll be able to provide any answers. If you have specific questions later, you can contact any one of us. We'd be happy to help. Thank you.
Okay, thank you and goodbye to all.
Bye-bye.